Okay, we are going to start now. Okay, I am Dr. Ashraf Armia from Cairo, Egypt. I am really honored today to moderate this Zoom live streaming webinar from Cairo, Egypt. It's an international ophthalmology meeting about a very hot topic in ophthalmology, post-cataract surgery surprises management. It's organized by EVA Pharmaceutical Egyptian company. It's my pleasure to have my dearest eminent international ophthalmology friends from all over the world. Dr. Shiraz Dia from UK, Dr. Fathi Fawzi from Egypt, Dr. Samer Hamada from UK, Dr. Ahmed Mustafa from Egypt, and Dr. Miltos Feliz from Greece. And now we are going to start our webinar. We are going to start our webinar with a very unique professor, Dr. Shiraz Day. I'm going to share very small thing about him because he deserves it. I must admit it, that we must say this. Congratulations to Dr. Shiraz. He's one of the 100 power lists in 220 and in 50 in 219 and 100 in 218. This is a very good and very hard work to reach this level of excellency. And we are honored that we are having you today with us, Dr. Shiraz. Please, you can share your screen.
Thank you, Ashraf. Very flattering. I'm very pleased to be here, and thank you for the honor and privilege of participating. Okay, well, I've been asked about talking about refractive surprises, and not to waste any time, this is something that can really aggravate all ophthalmologists. And the key is to have a methodology. This is my financial interest. I work with a lot of different companies. Some of the topics I'll be, some of them related to some of the topics today. So the most important thing is to avoid the problem in the first place. And that's really the bulk of my talk. I shall then discuss the surprises that one does get, and then the means for correcting them, which are actually very straightforward. There's only a few ways to correct these things. So avoidance, really, the most important thing is to measure properly. So as they say, measure several times and then cut once. Measure, measure, measure. Have your technicians, we use technicians, we certify them, we make sure that they're really up to speed in terms of measuring correctly and picking up problems. If you have to use several methods of measurement, then so be it. It's very important to use modern devices that are well calibrated in order to get the right sort of readings. And these include the interferometry devices, the IOLmaster 500, 700, the LensStar, AL scan from Nidec, and the Oculus from AXL, which combines the Pentacam and X-link measurements from Oculus. A-scan can be used too when you've got really dense lenses, but it's probably best to use immersion techniques when you use them. And the formulas really should be the new generation formulas. There's no point using the old formulas at all. And these are all accessible online through various means, the ASCRS website and so on. Now, again, in terms of avoidance, starting from the front of the eye backwards. So we've talked about measurements, but you've got to make sure the patient is suitable for surgery. Now, if they've got an irregularity of the surface, that is a problem. It could be from anterior basement membrane dystrophy, but more commonly, and I know Samer is going to be speaking about this, it's the tear film and the surface of the eye. When you've got irregularities, you know what? You can have errors like false astigmatism and also incorrect lens calculation. So this is one of our patients who came in wanting trifocal lenses, and you can see the whole eye is an absolute mess. It's streaky tear film, punctate epithelial keratopathy, anterior basement membrane dystrophy, and he's got a chalazion sitting at the top there, if you can see it. So he's not suitable for trifocal lenses, not at this stage. He needs to be fixed up first, and then go ahead and have surgery. Once everything is settled, then you can measure correctly. This is a great slide showing the impact of dry eye on keratometry. And this is done by Alice Petropoulos and a team of colleagues. They found that there's a 17% difference in keratometric cylinder between two visits based on osmolarity, and 10% had a half a diopter difference in IOL power. That, you know, if you're in a developing country and patients just need to be able to see, that's one story. But when you're living in in a part of the world where people are very demanding and they're paying a lot of money for good outcomes, and you need to get them spot on. So very important to measure correctly. The diagnostics you can use to see if you've got irregularity mainly are surface-based, reflective topography. And you can see that this is a Placido map with the OPD3, which I think is a great device, and it shows a surface irregularity index at 1.27. That's bad. That's in red. That tells you this patient has got a problem and this needs to be fixed. There may be many reasons for it, and it's up to us to determine this. And what sort of devices are out there? This is a list of them. I have some financial interest in NIDAC. I'm a consultant for them, but none of the others. But they're all very good. They all give you the same sort of information. What I find very useful, though, is this device, the HD analyzer. That really takes a look at the ocular surface, look at the ocular scatter. They have this ocular scatter index. And that looks at the overall eye, but you can also measure the tear film. And if the tear film's okay, then you can have to deduce that it might be the internal aspects of the eye, including the lens in particular, although it can also be influenced by the cornea and even the vitreous. So this is an ocular scatter index of 5.8, which is terrible. And this is development by Roger Zaldivar, his contribution, which actually measures the tear breakup time objectively. And this is very useful to show patients that they got a tear film problem. Until this is fixed, there was no way that we should be proceeding to anything else. This is a patient with a highly irregular cornea who was set up for a refractive lens exchange elsewhere. And he came to see me, but his cornea was extremely irregular. Take a look at this. But he had Salzmann's nodular degeneration all the way around. So what I did was I took off that Salzmann's nodular degeneration, as you can see me doing there. It almost extended to the visual axis. And this is an ongoing condition that he had. We need to get rid of it. And you can see that his refraction beforehand was +6, -4. Now imagine if I put a toric lens in him and he changed. And this is what he was like afterwards. And his vision was 6.6 unaided. And with correction, 6/4.8. He didn't need anything. He was so happy. Off he went into the sunset and didn't have any surgery done. And if you look at his lens calculations on the next slide here, you can see this is before we did the Salzmann's removal with keratometry, with IOL corrections of about 24.5, and afterwards 20 diopters. There's a 4 diopter difference in his lens power. So remember, you've got to make sure that everything's optimal when you take your measures. The other issue is astigmatism. A lot of people, I get a lot of patients coming to me for second opinions. They had toric lenses in. Doctors want to put toric lenses in because they're premium lenses. You make money out of them. Well, a lot of them didn't need them. And the way they did this without checking topography, they used the IOL master, an old IOL master, which gave wrong readings. You really need to use keratometry to measure astigmatism. And astigmatism could be irregular. It could be non-orthogonal. All that needs to be taken into consideration. Then there's the choice of the procedure. What procedure will you use if somebody's got astigmatism? Well, this is our own data from 15 years ago, where we measured patients who had LRIs and toric lenses. So the ones in red are the ones that are LRIs. Here's me attempting to do an LRI for somebody with 4 diopters of astigmatism. This is quite a long time ago. And I actually didn't do too badly, but I still undercorrected. And you see the trend line. But where it really changes is right here at about 1.25 diopters. And the younger people don't respond as well as older people. Older people over-respond, young people under-respond. So based on data, based on evidence, we only put toric lenses in patients who have 1.25 diopters and above of astigmatism, of keratometric astigmatism. Or if there are other issues like dry eye, where I don't really want to make incisions in the cornea and influence the outcomes later. In terms of shape analysis, it's very useful to look at 3-dimensional diagnostics to confirm the astigmatism, to also make sure there's nothing else going on, like in this case here, where they've got form-fruste keratoconus. You will not know this unless you use topography. You cannot use IOL master or K readings to make a decision about whether to use a toric lens or not. What about patients who've had refractive surgery? They are difficult calculations. Is another talk on its own. But what I tend to use is the holiday keratometry readings on the holiday report on the Pentacam, and I combine this with the holiday 2. You can also use the Barrett True K, which is a good way to do this, using the historical K readings, so a historical refractive correction and no historical refractive correction. I say that's that's another talk for another day. And sorry, excuse me. There's a sorry. So this is the as I said, a talk for another day. But this is a source of big errors in refractive surprises. So be careful. If a patient's had refractive surgery before, be very careful there. So what kind of surprises can they get? Well, they can get spherical errors. They can get, they can be plus or minus. They have quite a lot of astigmatism. This could be induced by the incision, but more often than not, it could be from the lens moving or inadequate correction at the time of surgery. Some of them have multifocal lenses. They don't get the presbyopic correction they want. Much of the time, it's because of an underlying refractive error that needs to be corrected. Or it could be because they're adapting. They've not been counseled properly. That's another thing to worry about. So in terms of approaching the correction, you need to find out why. Ask why. There's always a reason. There's always a reason. Check the lens calculation. Check the accuracy and quality of the test. Correct the lens in the correct eye. Make sure that you put the lens in the correct eye. And I've seen patients come in and the doctors have mixed up the two eyes. In fact, mixed up toric lenses between the two eyes, which just amazes me. I found it astounding. Look at the ocular surface. Was the ocular surface, compare it after surgery. I know Summer's going to talk about this, compared to before surgery. Did something change? Those medications we use can cause havoc. Then dilate the patient, do a full examination. Is the lens correctly centered? Is it in the bag? Is it totally in the bag? Now, if you notice in this particular case here, the lens is slightly out of the bag. The whole lens is in the bag. The haptics are in the bag, but the optic has come forward during maybe there was a bit of a leak after surgery. Everything came forward, and then when the eye filled up again, the optic was out. And this patient had a bit of myopia and also some astigmatism from the tilt. Now, these can be quite difficult to correct. They come to you too late. Look at the orientation of a toric lens if you put a toric lens in. So when you find out what the problem is, obviously it makes sense to treat the cause, but sometimes the cause may be difficult to treat because it's late in the day, or actually it's too small to treat. So what you need to do is take a look at the magnitude of error and look at the invasiveness of the choices that you have and balance it out. So what do I mean by this? Well, if it's the ocular surface, we'll correct this first and measure again later. In fact, sometimes we fix the ocular surface and the so-called refractive surprise is gone. Check lens positioning. If it's a tilt, correct it early. If it's a toric rotation, I usually wait 3 weeks for the capsule to contract, and then I rotate the lens. Because if I rotate it the next day, guess what happens? It moves again. So it's always better to let the capsule contract, tell the patient to be patient, and then go in and rotate back again into the right place. And I find that works very, very well. So if you don't want to get into the eye and the magnitude is small, what options do you have? Well, if it's astigmatism, you could correct using a limb relaxing incision. There are laser procedures that can be used, either photorefractive keratectomy, maybe even LASIK, and piggyback lenses are also another option. So limb relaxing incisions, this is if a patient has a multifocal lens and they've got 0.75 diopters or more, it may be that's causing the problem and making them upset with their vision. And this can be, this is an LRI done at the microscope, but it can be done with the slit lamp, and I often do this, especially if the astigmatism is a temporal or nasal. I'll just go ahead and be like Zorro and make the incision. But you're going to be pretty adept at doing LRIs if you're going to be doing them at the slit lamp. The femtosecond laser is what we use as a standard before surgery, and sometimes I do it if the magnitude is moderate. I'll do it again after surgery. In terms of laser refractive surgery, I prefer to do PRK because usually the magnitude of correction is quite small. But if you're going to do PRK, you really must take a look at the epithelial thickness maps of these patients. If you don't have access to it, find a friend who has epithelial thickness measurements and take a look, because if you do PRK, especially transepithelial film, any PRK, transepithelial or otherwise, you could have a second surprise afterwards. And I know because I have seen it. So the PRK is in my view, is preferable because there's a small refractive error, less chance of dry eye, but still, if they've got a dry eye, fix it first. And if you do LASIK, you want to do LASIK, why don't I do LASIK? Because when I put pressure on the eye, I could be opening up the incisions, the LRI incision, or even the main incision where I enter to do the cataract surgery in the first place. And that can change the power. And again, I might have to land up doing a further enhancement. And I do warn patients about this possibility. Piggyback lenses are great. We use them a lot, especially if they have a bit of dry eye or if they have form for keratoconus. I don't really want to be touching the cornea. Then I'll do that instead. So how do I calculate out the refractive error? I get asked this question a lot, so I'm going to answer it. I take the refractive error and I multiply by 10 and divide by 7. It actually works out to be multiplied by 1.42, and you've got your result there. So if it's a 2 diopter difference, multiplied by 1.42, and use that lens power and put that in the eye. You can use a 3-piece lens, as I'm going to show here on this video, or you could use and this is a soft port going into the eye in a patient who had a trifocal lens, and he had previous hyperopic correction, hyperopic LASIK, and wound up being still a little bit hyperopic. So we put this, he was hyperopic. We put this lens in to correct it. But you can also use the Sulcaflex. The Sulcaflex is very good. I just find it a bit big in the eye in patients. In this case, I chose a soft port because it's a thinner lens, and he had a short eye. He was previously hyperopic. So again, there's no hard and fast rules. Make sure you treat the patient exactly what they need, rather than a rule of thumb. So when it comes to refractive surprises, as I've hopefully illustrated, avoidance is really important. Acknowledge the surprise, and then find a means of correcting them using the methodology that I've presented. And thank you all for your attention.
Thank you, Shiraz, so much. It's a very valuable presentation for everyone. This is from your point of experience, a long time. You have some questions. Have you used the Aura?
Have I? Sorry, the Aura. Yeah, I used it, but it slowed me down. It didn't really contribute much to what I was doing, and so I abandoned it. We sent it back. Okay.
If you're going to choose between trans PRK or PRK and add-on lens, what's your percentage you are going to use?
Most of the time it's PRK. The only time I do LASIK is if there's a huge magnitude of error, or if they already have a flap. I'll lift the flap and I'll treat that. But otherwise, I avoid LASIK, only because when I did do this, I've been doing this a long, long time, I wound up having to retreat them again, because I induced new refractive errors. I didn't quite get them spot on. I find PRK very, very good, but if the epithelial thickness map is a problem, sometimes just taking the epithelium off, putting a contact lens on and getting to heal sorts out the refractive surprise. Often they have an epithelial thickness variability because they have dry eye. So if you fix the dry eye and then you take the epithelium off if it persists, that often sorts out the problem. Usually it's astigmatism.
Can I ask you, Shiraz? I mean, those patients are often unhappy with the refractive surprise, and they just come to you. They want a quick fix. They don't really want to hear about give me PRK with 5 days of pain and discomfort. Do you find it sometimes challenging to tell these patients, I'm gonna do this surgery for you, which takes 5 days to recover? While I had this problem before, and that's why I'm asking, and I found that LASIK actually works well. Yes, probably not the very small prescription, but patients like it because it's just a, as you know, quick fix, and that's it.
So I felt the same way when I started doing all this. And when I had to bring them back for more surgery, I had to look at the drawing board. I looked at the maps, and the wound that I had, and I go scleral, opened a little bit, induced some astigmatism. Yeah, it started causing troubles. So I said, and then they got severe dry eye when they were okay to begin with. And they would say, doctor, this eye that you did the treatment on sees really well, but it gets really uncomfortable. Well, I don't want to hear about that. And elderly people, if they're in the cataract age group, they don't feel as much pain with PRK. And transepithelial PRK is fantastic. They notice the difference as soon as they get up off the table. You put a contact lens on, it's not that uncomfortable. They can see. And yes, it gets better again.
Yes, you have a lot of questions. Why you wait 3 weeks for a notoric surprise?
So I made a mistake a long time ago, jumping on the patient and changing the lens direction back again, only for it to move again. And a patient of mine who could not come in to have a lens repositioned, and she was changing 30 degrees every day. She came in 3 weeks later and it stopped. And when I moved her back, she was okay. But patients had done in the past had kept moving. So I say, figure, you know, it makes sense. Let the capsule contract. Because why does it move? It moves because there's too much space in there, especially in myopic patients, right? The lens is all one size. The bag is a different size. It will move every time they blink. It's like a propeller, it goes around. But once the capsule contracts, then you open up the capsule in the direction you want to move the lens into place, get the viscoelastic out, and you're done. And it's hardly likely to move after that. Does that make sense?
Yes. Another question.
That as well, Shiraz. The exception, I would say, physio lenses. They sometimes they stuck so badly in the bag, and rotating them, it can be a nightmare. I don't say I rush it, but I don't wait too long. That's my point.
But I mean, they usually don't move very much if you get them right in the first place. Because they got this
and that case actually was very challenging. They got a very high, I think, I can't remember, it must be 6 or 675 astigmatism. And also it's not really too much of access, but it was, patients were not happy with the result because of the high astigmatism.
Okay, another question, because we have a lot of questions where it's a firing questions, Shiraz. In topography, which keratometry you choose in irregular cornea in IOL?
Irregular cornea.
Yeah, irregular.
In a regular cornea.
Yes.
I mean, if the cornea is regular, everything's fine. I will use the IOL Master 500 readings, but they have to make sense against topography.
Yes.
If they're, what I want to know is what the average power is on that cornea. If the cornea is abnormal in any way, I've got to go back to the drawing board and figure out what's going on here. And why is it irregular? If it's a regular cornea, I just go like everybody else. But every single one of my patients that comes into my practice gets topography every visit. Every visit. We use the OPD3 on every patient on every visit. It gives me a lot of information, especially the report that we devised with NIDEC. It's a cataract lens report. It's worth looking at. It gives me a lot of information before I even walk into the room to see the patient. I know exactly what's going on with that patient. So I think that's a hallmark of a refractive practice, is to make sure you've got all that information to hand.
Is a piggy bag IOL the same for hyperop and myope?
How do you mean the same? You mean the same lens?
No, the same calculation.
Yes, the same. I use the same calculation because it's close to home.
Okay. Do you have experience if the toric IOL rotate after 3 years?
Sorry, moving a toric lens after 3 years?
Yes. You have experience if the toric IOL rotation happened after 3 years?
No, I've never seen that happen. The lens can't, I mean, it's not possible. If it's in the bag, it's not possible. If it's in the sulcus, it is very possible.
Okay. How long do you prefer doing the PRK after cataract surgery?
Refractive stability, it's usually 90 days.
90 days. What about dry eye can happen post PRK?
Yeah, well, I need to make sure they don't have dry eye. So every one of our patients that comes in, before refractive lens exchange or refractive surgery of any kind, even cataract surgery, we check Schirmer's, we check the tear breakup time, we make sure the ocular surface is fine before we go ahead and do any kind of surgery. And the same applies again, doubly, if they're going to have a refractive enhancement. So if somebody needs PRK, I make sure the dry eye is corrected. And actually, often, once the dry eye is corrected, the refractive error improves. They don't need anything.
Okay. Do you find any surprises, refractive surprises, after correction of the refractive surprises?
Yes, and that's what I want to avoid. And those occur with LASIK, and they occur where the epithelial thickness maps following PRK were not correct, which is why I use them all the time. If I need to do an enhancement PRK, I'll look at the epithelial map, the thickness. If that's a problem, I have to try and understand why. Why do they have this differential heating? More often than not, it's from poor lid closure. They may have blink like ophthalmos, or they may have some sort of dry eye, or some sort of ocular surface inflammation or dysfunction. I need to correct that first. And often the epithelium improves, or they may have basement membrane dystrophy. But once I know what's going on, if the epithelial thickness is incorrect, I take the epithelium off, allow it to heal. And again, often that takes care of the problem.
Thank you so much, Shiraz. Waiting for the end because we have a lot of questions. But this is the short questions we got. Thank you so much.
All right, great.
And now I'm going to introduce one of my mentors in my life, Dr. Patho-Fawzi. He's the CEO and co-founder of our hospital, Al Watani Hospital in Egypt. He's a very long experienced surgeon in the most complicated cataract surgery in Egypt. I am going to do Dr. Patho-Fawzi. Please, you have your presentation.
Thank you, Ashraf. I hope you mean managing complication, not causing complications.
The management of the complication happening.
So what I'm talking about now, thank you, Ashraf, and happy to be here with you all. I'm talking about late in-back implantation for sulcus displaced IOLs. And I'm sure this would help, especially if you're talking about toric lenses and the surprises you might get when the lens rotates. I have no financial interest in any material shown. How did the story start? Actually, those patients who have displaced IOL in the sulcus complain of inadequate vision and monocular diplopia. How did the idea start? It started by actually, again, being a senior surgeon. I attended the era when the high myopic patient did not get an implant. And they had a dense PCO, and no one wanted to go ahead and do YAG laser for fear of the complications, especially retinal detachment. So when facing those cases, I wanted to clean the PCO surgically until I got one case when I could see the edge of the anterior capsule. So thought, why not try and dissect the bag open and try to implant the lens inside the capsular bag. But by that time, we did have the low power intraocular lenses. When I faced the adhesion between the two capsules, I severed them near the anterior capsule. It needed some patience until I got the capsule open. This patient had his primary surgery 7 years earlier. Once I had the bag open, I could implant the lens inside the capsular bag. You can see me here using the forceps to fold the lens to tell you how old this surgery was. We did not have the injectors at that time. Obviously, you get soft lens matter that had formed after the primary surgery. You need to clean that up. And hydrated the wound, and you could see now the lens is nicely centered inside the capsular bag, and you can see the edge of the newly found anterior capsule in front of the implanted new lens. This peculiar white line I'm highlighting now actually is very important landmark. It tells you where the anterior capsule edge meets the posterior capsule, and at this white line you start your dissection. So I extended the idea to treat the displaced lenses inside the sulcus. So you know that the capsule is intact and the bag is closed. So you aim at this peculiar white line and you start your dissection. Try to open the capsular bag. This patient had his primary surgery 6 years earlier. Once you start to open the capsular bag, this technique gets easier further on. It's the first opening, which is might be a bit of a challenge, but once it starts to open, just a bolus of viscoelastic, like you can see here, it forces open the capsular bag. Something like getting the experience of lifting LASIK flaps years after the primary surgery. Once the bag is open, then you can gently manipulating the already implanted lens into the newly opened capsular bag. It's worth saying that these patients that had trials of recentering the lenses and they get repeated displacement, that once they are entrapped inside the capsular bag, the lens stays central. This animation shows the simple idea of identifying the white line, picking up the anterior capsule edge, and combining mechanical and viscodissection to lay open the capsular bag that had been closed for many years. And once the bag is open, then implanting the lens inside the capsular bag like normal becomes easy. So this young girl had a refractive lens exchange for her high myopia, and she was not happy at all about her result and was referred to me, and I found that the lens was displaced in the sulcus with the intact posterior capsule and a closed bag for 3 years. So I started by polishing the posterior capsule. Now you can see that the lens is flipped upside down as well, and the capsular rix is small, which might explain the difficulty the first surgeon might have had to implant the lens inside the capsular bag. Small rixes and meiosis during surgery are among the 2 main reasons to cause this problem. So she needed widening of her capsular rixes by microcisor and a snip into the edge of the opened rixes. And now you can see me enlarging her rixes to facilitate implantation inside the capsular bag. Then we're flipping the lens into the proper position. And re-implanting the lens inside the capsular bag. This girl actually was thrilled with the marked improvement in her visual acuity after surgery. This lady had her surgery 4 years earlier, and I could not do the dissection of the bag while the lens was there because she had a dialysis lower nasal, which I will show you. I could see that on the slit lamp. So I had to be careful during the dissection. I thought taking the lens out will give more room for the challenging dissection of the capsular bag. Hopefully you will be able to see the dialysis at this area here, which needed a capsular tension ring, which obviously you can do except if you open the capsular bag and then go ahead and implant the CTR, then implant the lens inside the bag. So what I'm doing now is I'm implanting a CTR inside the newly opened capsular bag. And now implanting the lens inside the bag. So now we sorted out her dense PCO, sorted out the displacement of the lens, and now the lens is stable with the CTR inside the capsular bag, and the lens is implanted properly. An important thing that you often face with these cases is the soldering ring, because the bag has been closed for quite some time. So you get often encountered with a thick soldering ring when you reopen the capsular bag. I dislodge this soldering ring after I re-implant the lens inside the reopened bag. Then I go ahead with and remove the soldering ring using irrigation aspiration. I might still try emulsifying them. I saw Ashwin Agrawal doing them by phacoemulsification, which I believe is a good idea. I saw him in a webinar 2 days ago. What you often encounter as well is fibrosis of the posterior capsule, not only the anterior capsule, and sometimes it's a continuous sheet of fibrous tissue. Once you reopen the capsular bag, then you go ahead and try to dissect this membrane. Luckily, I've had some experience in doing vitreoretinal surgery at the beginning of my career, so I had the feeling of peeling epiretinal membranes and eye lamps. So I get the feeling when you went to stop pulling and grabbing another point, and with some patients, you can peel off these membranes of the posterior capsule. So we've now cleared the posterior capsule and reopened the capsular bag. and we can go ahead and implant inside the capsular bag. And last two cases, this is actually a patient of mine. I was training myself on hydroimplantation, so that's implanting the lenses without using viscoelastic, getting ready for the shortage of viscoelastic after the COVID is over. Probably will have shortage of consumables. Actually, it works well, but in this case, it was a toric lens, and the pupil came down while I was implanting the lens. And oriented the lens in the proper direction. Patient was happy after surgery. I was making sure the lens is inside the bag, but the patient came 2 weeks later, were quite unhappy, and found the lens is like inside the pocket of the capsular bag. So one half of the lens is inside the capsular bag, the other half is outside. Dr. Shiraz was mentioning this about when you assess patient with toric lens, first make sure that the lens is implanted properly inside the capsular bag. So I used this technique. Now it was easy because it was a fresh surgery 2 weeks earlier. Reopening the capsular bag was quite easy. Then I re-implanted the lens inside the bag in the proper orientation. And then my last video to show you that life is not always easy. I had what I thought was a defect here. I was not quite sure whether it's a defect or a transparent part of the posterior capsular membrane. So anyway, I went ahead and dissected the capsular bag open, but this area of adhesion here at this point was quite tough. It did not open, so I thought of excising this adhesion near the edge of the anterior capsule, hoping that it's just a band of fibrous tissue, but unfortunately this led up to an opening in the posterior capsule. So I went ahead and did vitrectomy behind what I have left with the posterior capsule remnants. And luckily enough, I thought that the remnants of the posterior capsule could be quite enough to hold a single piece intraocular lens inside the capsular bag, gently implanting the lens and slowly unfolding the lens until it stays inside the capsular bag. And obviously pressing the lens and pressing on the globe to make sure the lens is stable. Staying nicely on the remnants of capsular bag. So the take-home message that the capsular bag can be reopened even if it was closed for many years. This facilitates late in-bag implantation and correcting sulcus displaced IOL. And thank you very much for your attention.
Thank you, Dr. Fathi, for this eminent dealing with the late in-the-bag implantation. It's not an easy, as it's shown. It needs a lot of experience for a long time to do like this. It's not an easy to save the posterior capsule to implant again in the bag. It's not as it's shown, but due to you are a skillful person, so this is for you. It's a little bit easy. You have some questions. You have some questions. What viscoelastic do you prefer to open the bag? What type of viscoelastic do you prefer during opening the bag?
It has to be a visco-cohesive because it actually binds to, in a bolus and has a good pressure effect. So the visco-dispersive wouldn't work for dissecting the bag. So it has to be a visco-cohesive substance.
How do you know before you go for these type of surgeries that it's going to open or no?
I would say in 95% of cases it opens up. It's like when you do flap lifting for a previously done LASIK case. You don't have a firm evidence, but you always have a go to lift the flap. For some reason, it doesn't adhere toughly except at the edge of the anterior capsule where you see this white line. Once you pass this and you start your first injection of the first bolus of viscoelastics, it opens up. It gets easier and easier further on during the course of the surgery.
If these cases happen with a multifocal IOL, Do you open the bag and you put the multifocal again, or you transform the patient to monofocal IOL?
So do you mean if the multifocal was displaced in the sulcus?
Yes.
I would definitely do that, yeah. I would definitely do this technique. I reopen the capsular bag, try to be as gentle as possible, because this is a vision threatening problem if you lose the capsular bag. So I would do my best to reopen the bag and reimplant the lens inside the capsular bag.
Do you change the IOL from 1 piece to 3 piece after you open the bag, or you put the same IOL?
I try in most of the cases to put the same IOL as long as the biometry is okay. And if I'm using the same IOL, I only need 2 paracentesis or even 1 to do the whole surgery. Just when you come to removing the viscoelastic, either when you have a viscocohesive, you just can remove it by irrigation or a small diameter double-way cannula.
How many of your cases you couldn't put in the bag again and you put it in the sulcus?
Well, I shouldn't say never happened, but maybe in 1 case over hundreds of cases, I had to implant it in the sulcus. But in the vast majority of my series, the capsular bag could be reopened. I wouldn't say easily, but with some challenge and some patience.
Thank you so much, Dr. Fathi, and you have a lot of questions we are going to answer at the end for everyone.
Thank you, Ashraf.
Okay, if I can take over from you, Ashraf, for a minute.
Yes, sure.
I just want to say a couple of words, and I would say it gives me a great pleasure to introduce you for the next talk. I'm sure most people will know you. For those who don't know you, Professor Ashraf Amia, he's a very well-known, reputable consultant ophthalmologist, specialist in cataract, refractive, and the anterior segment reconstruction. He's actually a very good friend of mine, and I'm very proud of his friendship. He had more than 20 years experience in ophthalmology with a lot of knowledge and skills. He doesn't like to keep the wealth of knowledge to himself. He likes to share. That's why you see him very active on various national, international conferences, webinars. He's been so active in the current COVID time. So thank you, Ashraf, for being so active and bring people together to spread the knowledge. So your talk will be around unexplained cystoid macular edema.
Yes, thank you, Samer, for your words. It's my pleasure that you agreed and joined us. You are one of the best of my friends all over the world, and very sincere person also. Thank you so much. So I'm going to share my screen. When I thought about this presentation as a topic, I'm not a posterior segment surgeon, so I should admit in the front page that I'm going to talk about cystoid macular edema unexplained from anterior segment view perspective. I'm not a posterior segment surgeon. So I have no financial disclosure about my position or any material I'm going to use to say in this talk. These are my disclosure. When I prepared this presentation, I looked for a lot of papers in PubMed, and most of them was very recent. It means that this topic is till now it is a controversy topic for most of us. It's most of the papers 2020, 2020, 2019. All these are talking about the same cystoid macular edema. In uneventful phakic emulsification, it was straightforward, and this is what happened. Especially, it's bilateral. Also, some cases happen bilateral for the patient. So, cataract surgery is one of the most commonly performed surgeries. Cystoid macular edema following cataract surgery, also known as the Irving syndrome, is an important differential diagnosis of painless decrease in vision following uneventful cataract extraction. First to introduce this Irving gas, it was 1953. and the instance of clinically significant cystoid macular edema, which is a vision greater than 20/40 from an expected 20/20 or equivalent. This is the range from 0.6 to 3.6, with a peak incidence at around 5 weeks after uncomplicated cataract surgery. The majority of cystoid macular edema cases resolve spontaneously, which is this is the good in this situation, with vision returning to normal. But this is not the good scenario for every case. Cystoid macular is traditionally defined as a clinical significant macular edema, also on the angiographic picture also. The visual acuity of 20/40, best corrected visual acuity or less, has been considered the clinical significance of most studies when it decreased to 20/40. The gold standard for identification of cystoid macular edema has been by fluorescein angiography, prevalence in 9.1 to 25.5% of cases. A measurement of the macular thickness with the optical coherence OCT does correlate with the visual impairment. There is a numerous factor for this, but the theories suggested that macular edema arises due to increase in the vascular permeability following surgical procedures such as cataract removal, which cause the release of prostaglandin, disturbance of the blood-retinal barrier, with a post-operative release of inflammatory mediators and upregulation of a pro-inflammatory genes and proteins in the retina. Also, if there is unnoticed extent of vitreomacular traction or taut epiretinal membrane you didn't notice before surgery. What is the pathophysiology of mechanism? It's an excessive surgical trauma lead to increased inflammation, which triggers the cascade inflammatory reaction, leading to conversion of arachidonic acid to prostacyclins, prostaglandins, thromboxanes, leukotrienes, and other inflammatory mediators. These inflammatory mediators cause the breakdown of a blood-retinal barrier that ultimately increase the retinal capillary permeability and the extracellular fluid accumulation. Also, this is what leads to the petaloid pattern, which we usually see on fluorescein angiography. Also, the hyperfluorescence of the optic nerve, it's a late stage of fluorescein, and due to the late staining with the vascular tortuosity. Also, increase the macular thickening in cystoid empty spaces, leading to the petaloid pattern. The molar cells become swollen and lysed, then eventually develop cystic changes that result in varying degree of decreased visual acuity. The determined effect in the visual acuity may occasionally be persistent that lead to permanent visual loss. This is the bad scenario of these cases. Very important to highlight it, that if you find a bilateral cystoid macular edema in uneventful phacoemulsification, look for systemic disease like Crohn's disease and systemic infection. This is very important. And also the proposed etiological factor include inflammation, vitreotraction, and hypotony in the first 24 hours after surgery. The surgically induced trauma, which is the iris, ciliary body, lens epithelium, making disturbance in blood aqueous barrier, resulting in the release of the mediators, what we said. Also, some studies say that sphincterotomies to the iris, also the pupillae dilators, can lead to uneventful cases, can lead to cystoid macular edema post-op. This is the histopathology of the fovea. You can see the large cystoid cavities, which is seen in the outer plex form and the outer nuclear layers. Also, there is a disturbance in the blood in the retinal pigment epithelium layer. This study showed that it's in the bilateral and the systemic post-operative cystoid macular edema in patients, there is found that there is a macular telangiectasia type 2. This is in uneventful phacoemulsification. This is you should do, and this is why you must do an OCT for every patient, even if it's not has a systemic any disease, you should look for the macula before you do your phaco. How to diagnose it? Very easy. It's by the OCT, optical coherence tomography, and it's found in 13.9% of the cases, cystic spaces. As you take your cuts here in the macula, you can find, and there is a new sensory attachment, multiple cells, and the molar cells, you can see it very clearly. Also, very important to see, this is, they found it that there is hyper-reflective dots in the pre-retinal vitreous of the patient who underwent cataract surgery uneventful, and you have a cystoid macular edema not explained. You can see here there is hyper-reflective dots. These they explained by that these hyper-reflective dots due to from the lens fragment or represent the co-glutination of the inflammatory cells or the epithelial cells released from the ciliary epithelium due to surgical trauma or perhaps denuding the collagen fibers. This is very significant relation between these vitreous hyperreflective dots and the pseudophakic cystoid macular edema unexplained. You should usually see this in the OCT pictures. Influorescein, as you know, everyone knows, this is a petaloid pattern and the late staining of the optic disc. So how we can make a prophylaxis this to happen? Recommendations say that topically applied non-steroidal anti-inflammatory reduces the prostaglandin senses by inhibition of the cyclooxygenase 1, the COX-1, and the cyclooxygenase 2 enzyme, which decreases the post-operative inflammation for the patient. Also, if you are on topical anti-glaucoma treatment, rather than the prostaglandin, at least 1 week, you should stop it before surgery because this can increase the risk of cystoid macular edema development. This study showed that the role of the non-steroidal in the prevention and the treatment of the post-surgical cystoid macular edema. Then also we can talk about the non-steroidal in more detail. We have a lot of non-steroidals I'm going to go on according to different countries. Not all the non-steroidal are available in all countries all over the world. So the use of anti-inflammatory eye drops reduces the instance of the Irving-Gas syndrome by limiting the post-operative inflammation. We have the Ocufen, which is the fluorobuprofen. The dose is 1 drop in the conjunctival bag every 4 hours for 5 weeks. If you are going to use the Nipipinac, which is the Nipinac, it's 1 drop in the conjunctival bag of the operated eye 3 times a day, starting on the day before cataract surgery, then continued on the day of surgery and up to 60 days after surgery as the physician sees. If we are going to use the ketorelac acular, recommended 1 to 2 drops, 4 to 6 times a day for 20 days, starting 24 hours before surgery. If you are going to use the indomethacin, we are going to, it's 4 to 6 times a day to be started 24 hours before surgery. If you are going to use the diclofenac, the diclocid, 3 to 5 times a day for a maximum of 4 weeks to be started 3 hours before cataract surgery. These are the regimen by every company, they said. Preventive treatment of topical non-steroidal 1 month and topical steroid 15 is usually used with these protocols. There is a new era of the non-steroidal called the Prophylaxis 0.1. The dose is, this is the only non-steroidal that we can use twice a day, which is brominated non-steroidal anti-inflammatory with a strong anti-inflammatory potency. It's usually it's well tolerated when given alone or in combination with intravitreal anti-VEGF treatment or topical corticosteroid or topical mast cell stabilizers. If it happened already, how can we cure these patients? Because they are looking for the best for the vision, and you are saying to them, I didn't do anything wrong in the operation. I don't know what this happened, but you should counsel the patient and tell him that this can happen, and this is the instance happened to all over the world. I know I didn't do anything, but this can happen to you. We are going to try to finish this problem together. So it's a usually the protocol starting by oral acetazolamide diamox with topical non-steroidal anti-inflammatory is generally used as a first-line therapy. Usually, the usual dose is highly variable, ranging from 1/4 tablet 4 times a day to 3 tablets of 250 of the acetaldehyde per day. Most often with a progressive decrease over 1 to 3 months period. This is a study say that there is they use the intravitreal dexamethasone implant, also the anti-VEGF for the resistant pseudophakic cystoid macular edema. So the steroid we usually use what it can block the release of the arachidonic acid and the consequent inflammatory cascade. Also, it acts on the inflammatory mediators like the interleukin and the VEGF, and the fluid reabsorption by the retinal pigment epithelium. It can be single or multiple injections. They use the Orthodex, which is the intravitreal implant corticosteroid in the refractory macular edema secondary to diabetes or vein occlusion events or the pseudophakic uneventful cases. The Orthodex is the intravitreal steroid, which is the only label for the injection intravitreal, 700 micrograms of dexamethasone in the vitreous. It's a rod shape, 6 millimeter length. It's very important to know that it should only be used in these cases as a second line therapy in resistant cases, not the first line of treatment. But it gives a strong changes in the visual acuity, improved in 12 months, and it can be repeated after 6 months in 50% of the cases. What they are using now is some off-label drugs. They can use the anti-VEGF as a treatment of these uneventful cystoid macular edema. Failure or contraindication which have failure to the or contraindicated steroid intravitreal injection give a good effect, and vision improved by 2 lines in the ATDRS. Also, they are using off-label interferon alpha for refractory cystoid macular edema, pseudophakic, which is the Irving gas. This is a new study was published, and this is another study by interferon alpha 2A and 2B for ophthalmology. It's a very new study also. They are using it off-label. It's a topical interferon alpha 2B for these cases. It's an alpha 2B act against the various biologic targets such as the VEGF, interleukin 8, interleukin 10, TGF-B, and the TNF alpha. It's improved the barrier effect of the retinal vessels endothelial cells in the retina and can also penetrate the sclera despite having a large molecular structure. So this is a very big issue, happened to everyone. No one didn't see these cases a lot. So my home take message is, bilateral cases of Irving gas syndrome, you should look for Crohn's disease and infection. Very important, don't miss it, don't miss it. You can diagnose Crohn's disease before the general surgeon can diagnose. A patient who develops cystoid macular edema following their first eye cataract, you should stay with them, counsel them, and tell them there is a high incidence that it can happen to the other eye. And you should do the aggressive prophylactic measurement for the other eye. And I'm going lastly to put this slide. This is the the recent guidelines that they are using now for treatment of Irving gas syndrome, which have a decrease in the visual acuity. If the phaco happened with no incidence, so you are going to use a topical non-steroidal anti-inflammatory, which is a label, plus the topical steroid and acetazolamide oral. Steroid injection is not going to no improvement, and using the Ozurdex, which is the only label for intravitreal injection, or the triamcinolone, which is the off-label, which is subtenon or subconjunctival. If the phaco is happened and with a ruptured, so you're going to reconstruct what happened first and continue the track. If you have failure for steroid injection, you can inject VEGF or anti-TNF alpha, which is an off-label, or the interferon alpha 2A subcutaneous injection off-label. Thank you so much, and I'm happy that I'm sharing everyone this webinar.
Thank you, Ashraf. Can I just highlight someone from the audience have a question? Said, can you show us the curative TTT slide again for IGS?
Which slide?
He said, can you show us the curative TTT slide again for IGS? So we normally use influnomefran, prednisolone, and Nivanag 3 milligram or NSAID, and that brings very good results.
Okay, I'm going to share it. This one?
Yeah, that's yeah, I think that's a question about the
the Nivanag, yes, the one. It's one drop into the conjunctival bag in the operated eye 3 times a day, starting 1 day before the cataract surgery.
Okay, so Ashraf, can I ask a question? You have a patient. What things tell you that? First of all, do you use NSAIDs as a routine in your cataract operation? And 2, if not, do you have a selective, like a group of patients where you prefer to use NSAIDs for them?
Yes, non-steroidal anti-inflammatory, I usually use it for diabetic patients, long-standing, even if there is no diabetic changes at all. Any uveitic patient have a history of uveitis or anterior cyclitis, and now he's totally cured with nothing in the eye, I usually start. Any patient with immunosuppressive diseases, I usually start. Any patient under having systemic diseases and he has a long-term using like a bronchial asthma, he has a chronic diseases for a long time, I usually start non-steroidal anti-inflammatory.
Okay.
With the cataract surgery.
Nice. So someone...
Can I just add the panel? What about recurrent cystoid macular edema? You treat it once, it comes down, and then after 3-4 months, it happens again. And we see that sometimes in transplant, corneal transplants, post-op, they see that they come again and again. What is your regime? I mean, what I'm doing basically on the second time, the third time, I just put them on a non-steroidal for a long term, like 6 months, maybe more. But is there anything else that we can do if we have this recurrency? What is your point?
Usually, if I have a recurrence and I didn't inject intravitreal steroid, this is my policy. If I have a recurrence in the first 3 to 6 months, I go for injection of steroid.
If you have done this, if you have passed this step, you have done the injection on the second, and then you have it again after 6 months or a year.
I repeat the OCT, and I'm going to look for any thought if retinal membrane have developed, because recurrent or chronic cystoid macular edema usually happens if there is missed epiretinal membrane, or if the patient is systemically have a problem.
Okay.
And Ashraf, does that affect your decision using premium lenses? Say someone you think they might have or might develop CMO after surgery, and they want multifocal implants.
Yes, this is an issue, and usually if a patient is coming for a multifocal IOL and I have suspected cystoid macular edema, I usually say to the patient and counsel him. I always tell him that we have a chance, like the diabetic. I usually tell him that you don't have any diabetic change, but you have a diabetes for more than 20 years now. Your A1C is controlled, I know, but there is a chance when you open the eye and do the phaco surgery, you can have the cystoid macular edema. So if he agreed and if there is any complication happening, we're going to manage, it's okay. If he said, no, I understand, so I don't go for multifocal IOL or PMIOL.
Okay. There's a question from the audience. How do you treat paramacular edema? I have to say, I don't know what's paramacular edema.
Paramacular edema or focal macular edema, it is not a Irving-Guest syndrome. Irving-Guest syndrome, it has a picture. It has a petaloid pattern in the fluorescein and late staining of the optic nerve. This is what the talk says. But parafoveal macular edema, it can be one of two. It can be macular telangiectasia, which is the common, or it's a diabetic patient has a focal macular edema. So if it's a diabetic macular edema focal, if it's outside the 500 micron, I'm going to do a focal selective laser, PRP, laser, argon laser for this patient. If it's a macular telangiectasia, I'm going to do an OCT angio and see if there is any edema in the choroidal areas, or I'm going to follow up the patient.
I have a question to you, Ashraf, please. If a patient had a persistent or recurrent macular edema, do you further evaluate the anterior segment by further imaging, like might have a problem with the capsule or the lens that's not very evident clinically?
Yes. Persistent or recurrent macular edema, and you are feeling that you didn't do anything wrong in the operation, it may be something in the systemically in the body or in the angle. You can do a UBM for the patient. You can see if he has a glaucoma, open angle glaucoma, iris,
a decentered IOL, touch with the iris, or
inflammation in general, I believe. Yeah. I mean, these patients do have an inflammation somewhere. It is not uncommon that when we do phaco-DSEC or phaco-DMEC to have postoperatively cystoid macular edemas, and this is again because we are, introducing a lot of inflammatory factors that we will deal in later on. I mean, in my experience, phaco-DMECs and phaco-DSECs as well do have higher incidence of cystoid compared to their standard phaco. I think inflammation plays an important role on that.
If I may add as well, when you do the gonioscopy for these cases, you have to look for retained nuclear fragments. Sometimes small fragments are staying inside the angle and can cause persistent inflammation.
Or in the sulcus, the Patho might be hidden in the sulcus as well.
Yes.
Ashraf, before you go, can I just say there is two good questions. One is about using, they call it draining drugs in association with the, I think they mean Diamox, acetazolamide, if you use those. And another question about risk of corneal melts in those patients. And that covers most of the question. Yeah.
Yes, there is a risk of long use of non-steroidal anti-inflammatory corneal melting, but this is not happen to every patient. It should be any problem before in the cornea as a peripheral marginal degeneration, or he has a peripheral marginal degeneration, or he has a severe dry eye before the operation. It can lead to exacerbation of the use of non-steroidal anti-inflammatory, but this is not the common complication.
Okay.
So now I'm going to introduce a very sincere friend to me. He's a very talented all over the world in dry eye diseases and ocular surface management of any problem. Dr. Samer Hamada from UK, he's one of the experts in dealing with cases of dry eye by all grades. He's very known in this field worldwide. Please, Samer, you have your presentation.
Thank you very much for the nice introduction. I'll just share my screen. Can you see me well now?
Yes, perfectly.
Good. Okay. Well, thanks for organizing this meeting. Thanks for the organizer and the supporter. So my bit here today is about dry eye disease of those patients who undergo the cataract operation. And the points I'm going to cover is who are those unhappy patients and why dry eye affects the outcomes of cataract operation. We need to know who is at risk and the management from the time before the surgery, which I think is very important, to intraoperative and then post-operative. So let's start to think about what are these most predictable or most unpredictable surprises. So as a term says, surprise means that you're talking about a complication you're not expecting. And that might not apply, that could apply to CMO, uveitis, refractive surprise. But when it comes to the most predictable, actually dry eye disease. Often you know who's the patients that might come back to you and they're having problem with their ocular surface. And if you look at the FACO study by Bill Trattler, and it's very good work because they looked at those patients coming for cataract operation, they have their assessment, and if you look at the results here, it's really a high figure, talking about 87% of patients before they have the cataract operation, they're already diagnosed dry eye disease. A quarter of those patients, 26% of those patients, already they're aware that they have a dry eye disease and they're coming for the surgery. And when you look at the table on the right, you can see that those who stained, tear break up time less than 5 seconds, 62%. And those with the corneal staining is quite high. Positive staining is 76% of those patients. These are a group of patients across the board, no selective criteria here. It's just any patient coming to cataract operation, see how many of those dry eye. And we know that cataract operation itself is really contribute to dry eye disease in various ways. So for example, it affects the tear film from causing meibomian gland dysfunction, loss of goblet cells, increased inflammatory markers. It's a trauma, it's a surgical trauma to the eye. And corneal sensation reduced, and that could be related to the incisions or the inflammation process itself. But we know that the sensitivity of the cornea can be reduced up to 3 months after the surgery. And another important fact, we miss it sometimes, it's the eye protection is not as used to be. If someone is a borderline lag of ophthalmos, it shows more. If they have a bit of poor function of the eyelids, it shows more. So who are those unhappy patients after your operation, cataract surgery? These are either the one on the left, develop astigmatism, or left with correct astigmatism, which covered nicely by Shiraz earlier, and those with the dry eye. Those are the patients that are really struggling. And the dry eye after cataract operation, it's up to 55% of the patients come back to you and have a dry eye. Luckily, 65% of them have a mild disease, but the remaining actually have a quite severe disease. And they come with various symptoms. They could say, well, my vision keeps fluctuating, my eyes sting burning, they're dry, they're itchy, sensation, sensitive to light, and don't forget, eyes are tired. These are come from studies where it showed these are the most prominent symptoms patient report after cataract operation. And we like to believe in ourselves. And sometimes you find actually, I call them, this is an unhappy 20/20 patients. These patients can see perfectly well. They are 20/20 patients. And we believe they're great. We've done a great job for them. Patients don't see it that way. They feel this is a miserable life after this operation. They can't drive, they struggle to read, vision keep fluctuating, I can't open my eyes for too long, I'm embarrassed with the redness of my eye, etc. It's becoming more challenging if you really put those patients through the premium lenses, multifocals and the torics and etc. Then you find actually 20/20 is definitely does not really match with the patient satisfaction, because you've got 5 to 15% of patients with excellent visual outcomes, but they're not happy with the quality of the vision. And we're dealing with a big problem here, because remember, those patients you're operating on, they are 45 plus. This is from with the refractive lens exchange all the way to cataract surgery. These are the groups, a large group of patients with dry eye. We're talking about 30% almost patients have this condition. And I keep putting this slide because I'm so in belief that ocular surface stability, the microenvironment stability is the key. You want to restore the homeostasis, ensure the patients can continue with their normal homeostasis. So you want to try to make every step you do from pre-assessment, managing them before the surgery, intraoperative and postoperative as less traumatic as possible. You want to be gentle with these eyes, especially if they're borderline to break. And don't just look at the cornea itself, because that slide shows you actually every component on that ocular surface contributes to the stability of that ocular surface microenvironment, from tear film, the conjunctiva, the vessels, the lymphatic, the immune system, the cornea with all its layers, lids, and etc. So when you see those patients before the cataract surgery, what you think? I want to pick up those cases at high risk, or let's call it eyes at risk. Those have signs, no symptoms, and I'll show you those group of patients in a second. Those with rosacea, they're likely to have exposure keratopathy, or they already have it. Those with immune deficiency and problem, or already they are dry eye patients, but mild. Because if you look at the Dew's report, the way he looks at the patient, it's really amazing how it just narrowed things nicely to show us. If you follow this, you can see that this is a presenting patient. My mouse not working, but so if your patient present to you, and obviously they have a symptoms and sign, this is a dry eye disease, that's easy case. Let's look to the left. These are the patients, most likely they have no symptoms. You examine their eyes, they're coming to you for a cataract operation. You examine their eyes, you find loads of staining. You find a lot of problem with the tear break-up time, reduced meniscus height. Then these are a group of patients going to have a surgery, cataract operation. They have no symptoms, but they have signs. These are difficult patients because this patient, you're telling them, you have a problem with your eyes. They're coming to you for a cataract, routine cataract operation. Suddenly you put them into category of patient need another treatment before the operation. So based on that, the diagnosis come into saying, okay, these patients are borderline. And in fact, your surgery, your good hands might induce that poor balance and restore, break that balance, the homeostasis, and patient will end up with dry eye. And Dew showed you a nice way how to diagnose dry eye disease. So basically the patient will come to you complaining of problems. They must have a symptoms, and those patients show one of the signs such as tear break-up time less than 10 seconds. They have an ocular surface staining more than 5 spots on the cornea or 9 on the conj, and they have osmolality. One of those three enough with symptoms. So if you look back again here, you find those patients asymptomatic with signs, they're still not a dry eye patients. It's just the symptoms will start to show up after the operation. And you probably better to use validated questionnaire. So nice to ask these questions to the patients. Routine, if you like, if you really want to minimize to certain group, then those patients at high risk, then you can ask them these questions. I like to introduce what you do already, but just remind the basic to everyone is it's called 2 minutes test. The 2 minutes test is basically 1 minute is you doing the fluorescein drop, and I'll encourage you all to use the fluorescein strip. And if you just drop that fluorescein in the eye, ask the patient to blink. That's the first minute. And while they're blinking, look at the slit lamp. You measure tear break-up time. You measure tear meniscus height. By the time they pass 30 seconds, now you start to show the staining. Staining will not show straight away, so you have to wait a little bit. In the second minute, you start, I mean, that's probably throughout the observation, but you look at the lid margin. You try to assess, is the eye red, the lid margin inflamed, what's like the telangiectasia, thickening, etc. And then you do the dynamic examination, that pressing the glands, pressing them to see what's coming on them. I would like to see what the type of meibomian come, and I'd like to see whether these glands are obstructed or running flow nicely. If you have the luxury to have all these devices, obviously you can measure the tear film thickness and the lipid layers, etc. Now, remind you just a blink. A blink in ophthalmos is very common. This patient, look at her, she's a dry eye patient, she doesn't blink fully. And if you observe her carefully, you find that she had this long blinks. This is called extended blink closure. This lasts 6 times more than the normal subject. Those are patients, they don't blink fine, but then after every few blinks, suddenly happen, they feel, oh, my eyes are so dry, and they blink so forcefully. And you can call this called the micro sleeps, if you like. This is kind of in a fatigue status. So those are cases that you have to really identify before cataract operation, and sometimes can be very subtle, but you can pick it up. Sometimes they show, look how she squeezed her eyes. She keep it closed and closed and closed. Takes long time to recover and come back to normal. So those patients might end up staining on the surface of the eye. And one thing, we still before the surgery now, remember the psychology. And why this is important, through the talking to patient, you can gather information. Is this patient likely to be a problem to me under themselves after cataract operation? Because if you know the patient of type A personality, for example, they like everything to be perfect and they won't accept a bit of fluctuation in vision because of dry eye afterwards. They can be very difficult patient to manage. So really important to think about what type of personality, and that might make you change your decision about what type of lens. If someone Mr. or Mrs. Perfect, I probably want to go for multifocal lenses for various reasons, but for me, most important here in this talk is because if they have a dry eye, if they're borderline for dry eye, they're gonna be a really difficult patient to manage. And Shiraz nicely looked at that, at how the K readings can be so all over the place if you have a dry ocular surface. But let me remind you, dry eyes is also a problem in the period after the surgery. Because these patients need to recover, heal well, you need a good tear flow, a good normal microenvironment to allow for good healing. Otherwise, the healing will be delayed. The patients will have, the corneal nerve will be affected, so they might end up with a long-term pain and dryness, poor neurotrophic function, poor trophic functions, high risk of infection, and these are symptomatic patients. And this is how they flow in my patients. So I see a patient coming for cataract. On the left, they have ocular surface disease. If it's a mild, I would say I'll treat them. If it's a moderate to severe, I send them to dry eye clinic. Some people say, I'm doing this cataract operation for patient. I don't want to run a dry eye clinic here. Fine. Either you separate those patients and treat them as dry eye clinic or refer them somewhere else. So let's go back to those mild cases. Those can benefit from 2 to 6 weeks of MGD management, mask, massage, etc. They come back after 2 to 6 weeks. They assess. If they still have ocular surface disease, I probably go to another layer of anti-inflammatories, plugs, thermal treatment, meboflow, etc. If that's still disease, then they have to go to dry. They need more management, obviously. If there's no ocular surface disease, when I say OSD, I mean anything, including dry. Then those patients can proceed with the surgery if they manage well. So no surgery unless I'm convinced that ocular surface is nicely controlled. And sometimes it's just a bit of, before the surgery, a bit of instructions, how to look after your eyelid margin, disease modification, elimination of risk factors, environmental changes, etc. Omega-3 supplement. I look by the evidence. We know these 4 items got a strong evidence to support them: the eyelid hygiene, AMG expression, the tetracyclines, and cyclosporine. And don't underestimate how important these patients are prepared. Almost all my patients will go through this: lid hygiene, heat application, at least 2 weeks before the surgery. And the way they massage the gland is very important, but we don't want to go in depth in that. Flaxseed oil, really important. I give them the supply. The earlier they start for surgery, the better. A lot of patients start on topical cyclosporine. Again, remember, it's not going to work in a week or 2. You have to start them quite good 6-8 weeks before the operation itself. A lot of them, they come for a thermal treatment and meibomian gland expression within the week before the operation, and that works very well for them. Especially, you know, the compliance can be very poor with those patients. Now, in the operation itself, you want to make it a gentle surgery. You want minimal trauma. You want to be minimally invasive. You want to protect the surface. Avoid those topical anesthetic drops, the tetracaine, which is really toxic to the ocular surface. Use of viscoelastics, HPMC to cover the cornea. Allow the eye to go through this quickly, happily, with minimal inflammation. And don't forget using topical and subcorneal steroids as required. Now, after the surgery, always think dry eye. If the patients come to you and they say, vision fluctuating, I'm not really happy, something not right, think dry. Sometimes they just tell you, my eye's tired, don't know what's happened to me, I'm not sure. This is think dry eye. Use artificial tears, you give them preservative-free drops. We said avoid NSAID because yes, in inflammatory, severe inflammation, the cornea melt can happen, and continue ocular surface treatment as before, they start before, and don't forget anti-inflammatories like cyclosporine might be beneficial here. Be prepared, and you need to tell these patients management can be long-term, and our exchange might be even required. And don't forget, some cases can go really bad, and the patients end up with the medical legal issues with them. In terms of treatment, I don't want to go through the layers of treatment, but what I'm trying to highlight here, yes, step 1, as used advice, they've got a lot of small things, simple things like modification, elimination, addition, looking at the risk factors, lid hygiene, etc. But Don't be afraid to jump into a measurement in step 2 or 3, where you can do some in-office treatment, the IPL, amniotic membranes, serum eye drops in the very bad cases, and even punctal plugs, etc. So management is very important. The way I think about the ocular surface inflammation and management, I think, okay, I need depends on the level of the disease severity, and look at level of inflammation, how bad is the MG function, and tear homeostasis, and I choose one of those treatments listed here. The one highlighted in red are the one that got good evidence behind them. So I'll finish with this 2 slides. So how to choose the right treatment? Well, you have to think about, do I know the etiology here? Do I know why this happened? Is just a cataract, or the patient have pre-existing disease that's just showing off now? And about severity, severe disease, be aggressive. And you need to treat early. No point waiting too long, because the earlier the better. Otherwise, you allow more inflammation and the vicious circle goes on and on. And think about, obviously, risk-benefit of any therapy to give the patients. So the key messages from my talk here is, before the treatment, and this is where you need to start treat this, you have to treat those patients before they ever are in theater. You have to be well in advance. You have to think whether you want to use premium lens for those patients if you think they might be a dry eye patient or have a problem. And psychology of patient will help you to know that whether this patient will be really suitable or not for that. In the operation, as I said, try to have some modification of the surgery to your routine surgery to make sure the inflammation is controlled and minimal. And after surgery, think dry eye disease if the patient is not happy with the results and the refractive look fine, and really, as I said, aggressive early post-op management. But always please remember, wherever you are in stage pre, during, or post-op, you try to keep the ocular surface microenvironment as stable as possible. And thank you very much.
Thank you, Samir, so much. It's a very informative, really, presentation about dry eye, and every one of us can do a perfect cataract operation, and the patient is still unhappy. He can see 6/6, but he's not happy at all. Yep. This is we face it a lot in our practice, and because we miss the dry eye, this is happening. You have some questions? Does topical tetracycline has the same effect as systemic administration?
Well, we have a very limited access to topical tetracycline. We have azithromycin topically, and I don't have a big study group to describe, but I use azithromycin on some patients, and I don't think the numbers I have treated enough to give evidence, but yes, it works for some patients, it doesn't work for others. I don't know if Shiraz can have any experience from UK, because in the UK we have a limited topical tetracyclines. Okay.
Do you do? They said they do your cases without topical tetracycline, topical anesthesia.
No, I use, but I don't use tetracaine. I use other. I use proximethicane, for example.
Okay.
And we use intracameral. Yeah.
Okay. Yes. What is the role of dry eye in femto second laser assisted cataract surgery versus phaco dry eye femto versus phaco?
Well, okay, you can think about inflammation again here. So I don't think I read the papers, but I'm sure there are a couple about comparing phaco compared to femto in terms of dry eye. But I can tell you, small incision versus phaco, they found dry eye is worse with a small incision cataract operation compared with the phaco emulsification. So based on that, I'm assuming that because the femto laser might be less traumatic to the ocular surface, then hopefully the dryness would be less, especially with wood construction itself.
They asking, in which situation do you use the Curative? How do you prescribe it, and how many drops per day, and for how long, many days?
So what
drug? How long?
Sorry, which drugs?
The Curative.
Ikervis, okay, yeah. So this Ikervis is cyclosporine, right? It's based as a nanoparticle delivery to the soft tissue. The epithelium is quicker and faster, and that's how it works better compared with Restasis or other things. That's the logic. Now, I have to say the cyclosporine with the Ikervis is 0.1%. It's not that strong concentration, but it still works as anti-inflammatory, and is proven like by NICE in UK as a treatment for severe keratitis in dry eye disease. So if I remember the question, how long? Basically, you need to give the patient initial 3-month treatment once at night. I mean, you can go more, but the license is once at night for 3 months. And you review the situation. If they get better after 3 months, good, you continue. They might have to go with it for 6 to 12 months, even more. If there's no response, you know that by 3 months. Sometimes either you have to go for high frequency or use ointment like Optimmune eye ointment, or go for tacrolimus, for example, different type of non-steroidal immunosuppression treatment.
The last question, your systemic treatment of choice of dry eye disease, tetracycline or azithromycin?
Good. So I think there is a good study, randomized controlled trial, looked at the azithromycin versus doxycycline, right? And they found actually you get a kind of similar benefit, and the safety profile may be better with azithromycin. So the benefit, the way they do it, so azithromycin, you give 500 milligram day 1, then 250 milligram for 4 days. That's month 1, then repeat that months 2 and 3. So like 3-month course. And the doxycycline will be 100 milligram once a day for initial period of 3 months, but can go up to 6 months. They found those 2 benefits. And I give the patient choice. Some patients feel, I don't want to keep using tablets every morning, it's difficult, I forget, etc. Then azithromycin will be a good short course, giving the same benefit.
Thank you, Samir, so much. I'm waiting for the last for our question. I'm going now to introduce Professor Dr. Ahmed Mustafa. He is one of the leading surgeon for glaucoma in Egypt and in the Middle East. He's has a long career in glaucoma surgery. And the most important that he's leading the career of young ophthalmologists to build up a society for glaucoma trainee for all the young ophthalmologists in glaucoma. Please, Dr. Ahmed, you have your presentation.
My dear Ashraf, thank you very much. I'm really honored to be with you and to be with the great friends today. So thank you very, very much. Now, is the screen seen right now?
Yes, it's very clear, Dr. Ahmed.
Yes. So I'll go through the topic of the post-operative rise of the intraocular pressure. Definitely after cataract surgery, when you operate on a glaucomatous eye, or you had a complication, or you operate on a child, you can expect a glaucoma. But the big problem is that when you go through an uneventful phase where everything is perfect, and then you should be, and the patient, you should be all happy, and then you get pressure spike. At that time, this is called a real surprise. Then for the incidence of that, it is not low, really. It is from 18 up to 45. The experience in intraocular pressure greater than 28, which looks like a quite percentage, and up to 10% report pressure greater than 30 during the first 24 hours. And some patients spike for a pressure of 68, and that should be a very serious level of intraocular pressure. The pressure usually starts within the first few hours, like the first 4 hours, and then it peaks 8 to 12 hours, and usually return to normal by the first 24 hours. So that if you are going to see your patient after 2 days, actually the patient should have passed through that pressure spike. For the course, it's quite interesting that most of the pressure spikes are transient and benign. But really for individuals with glaucoma, those pressure spikes might add further damage to the optic nerve. So those pressure spikes are very serious in some patients, like in patients with glaucoma. And glaucoma patients are also more likely to experience pressure spikes more than the others. Then when it comes to the etiology, it's really multifactorial. If you can see, it is retained viscoelastic surgical trauma, posterior capsular tear, retained nuclear debris, like Dr. Fatih have just pointed to the fragments in the angle, it could be in the sulcus as well, pre-existing susceptibility to glaucoma, release of iris pigments, hyphema, uveitis, specific entities. But I'm actually going to touch upon some items which are more frequent than others, like the retained ophthalmic viscoelastic devices, posterior capsular tear, and patients with pre-existing possibility of glaucoma. For the OVDs, as you know, it's a cohesive and dispersive, and cohesive is used to maintain spaces and help in the dissection and push the posterior pressure. And for the dispersive, they are used basically to protect the corneal endothelium. And actually, cohesive viscoelastics are more able to elevate the intraocular pressure rather than the dispersive. So that if we have a patient with the left residuals of OVDs and he is predisposed to glaucoma, those patients will get pressure spikes. It's interesting that those OVDs also adhere more to the acrylic lenses, which will need a lot of work. So that when we look here, like for these dispersive viscoelastic, like the methyl cellulose, actually, after the implantation of the intraocular lens, you will find it's not quite easy to get the viscoelastic completely from out of the eye. Whatever job you do, you're going to leave some of the dispersive, but fortunately the dispersive produces less pressure elevation than the cohesive. Then when we have a posterior capsular tear, this actually turns the story because there is a possibility of pressure spikes in 20%. So imagine like this beautiful case, looks like having soft cataract, and then you should be happy and expecting good results. Now you are polishing the posterior capsule, and then all of a sudden at the time of polishing, then you got a tear in the posterior capsule. So that you feel everything is upside down, and now you are in a different story actually. And then you will start pushing viscoelastics to push the vitreous, and some of those viscoelastics will escape into the vitreous cavity, and then you have to have a good efforts at the end of the surgery to get the viscoelastics from the vitreous cavity. So it seems like something simple will turn everything upside down. And then in this situation, a patient with posterior polar cataract, and you expect to have a posterior capsular excess with some viscoelastics passing into the vitreous cavity. At the end of the surgery, you should have a good work here to remove the viscoelastics. And after removing the viscoelastic from the anterior surface of the lens and washing as much as we can, and then at that time you can see a lot of debris and a lot of helon in the anterior vitreous. Actually, you can't leave the eye like that, otherwise you would experience pressure spikes in the immediate postoperative period. So what I do, and what I think everybody is doing, you just go to the edge of the lens, and then you will go to the anterior vitreous cavity, and then you will aspirate the vitreous. Definitely, if you have done anterior vitrectomy, that will prevent vitreous strands from coming to you. After removing the helon, still you feel there are some residue here, and then you go again for lifting of the intraocular lens, and then removal of the rest of the helon, so that I don't feel secure unless the whole OVD, especially the cohesive, has been removed. And sometimes I inject myopole at the conclusion of the surgery. That could help in prevention of pressure spikes as well. Again, Dr. Fathi just have shown this hydroimplantation. You need viscoelastic at the time of capsular excess, but actually you don't need viscoelastic at the time of lens implantation, but this should be a one-piece intraocular lens. If you are using both hands, you can do that. So that again, you keep the irrigation inside the eye, and then you push the intraocular lens, and then you have small amount of viscoelastic anterior the eye, inside the eye to be removed. Again, here I'm injecting, you will have some viscoelastic, again, it's in the nozzle of the injector. And then when the lens went into the anterior chamber, the leading haptic was a bit twisted, so that again, I will just push the lens. Everything is done under fluid. There is no need for a viscoelastic. Again, I'm going to push the lens back, but the lens is a bit decentered because the one haptic is twisted, so they're still under the fluid. You can do some maneuvers like getting a haptic and adjusting the position of the haptic and then pushing it back, so that under hydro, you can do a lot without the use of viscoelastic at the conclusion of the surgery. Perfect and experienced surgeons, they experience less pressure spikes than the beginners, and this is a fact. So the 4 difficult cases, we give them to the experienced surgeons. For the medications, systemic carbonic anhydrase inhibitors are effective. Alpha agonists, when they are used before the operation and after the operation, can reduce the pressure spikes, and fixed combination of dorzolamide, timolol effective as well. So when we focus on glaucoma patients, they are more likely to have pressure spikes, and it's more damaging to them. It's not only the glaucoma patients, patients with ischemic optic neuropathy as well, like patients with anemia and systemic hypotension. You should keep an eye on those patients to avoid pressure spikes, very damaging to them. Then this is a story of a patient. The patient was just liable to have glaucoma, or that patient was open-angle glaucoma and on full medical treatment, and then there are some protocols suggesting only cataract, and actually when the patient is on full medical treatment and then the pressure is just controlled, please go for a combined surgery, because those patients are having an outflow facility that's reduced. With the addition of the inflammatory response after the operation, they will have an intraocular pressure that's not controlled. So sometimes you need to go for an operation under not a situation which is not very favorable. Again, for the glaucoma patient, any kind of intervention, like in this patient, she has a very nice intraocular pressure, it's 11, but the point she has a bleb, which is, it's a functioning bleb, but it's not good looking bleb. Again, after cataract surgery, the pressure was raised to 30. So even with functioning trap, expect some pressure spikes. Now look for this patient. She presented with cataract and old bleb. And then I just had a discussion with the patient, should I remove this bleb and refresh your ocular surface with a new conjunctiva? And fortunately, the patient did not accept. She asked me to just go for the cataract. And then what happened? And actually that after the cataract, despite that the bleb was really functioning and the pressure was aid pre-operatively, in the post-operative, we went through pressure spike. So the glaucoma patients are usually having that risk. So as a proposed guideline that identify patients at risk, those who are having damaged optic nerve, or they are glaucomatous patient, please, you can put them prophylactically on acetozolamide after the operation. Also, you need to ensure complete removal of the viscoelastic. You can inject intracameral myotics. Aggressive therapy if there is a posterior capsular tear. Again, if you do not feel happy about the patient, ask the patient to come on the same day. You can do paracentesis and you can repeat it, and sometimes you can get some of the viscoelastic, and occasionally you can go for an emergency surgery. There are special situations where you can get elevation of the intraocular pressure, like malignant glaucoma, phacoantigenic glaucoma, pigment dispersion, Fuchs, capsular blocks through exfoliation, steroid induced, a great list of cases. So with pseudo exfoliation, you can get pressure spikes even after surgery. You can get malignant glaucoma, especially in eyes with previous attacks of glaucoma and YAG iridotomies. So you can get even after cataract surgery, malignant glaucoma. It's not specific for the glaucoma. Now for the capsular bag distension or the capsular block, again, this is my drawing. It's just when you have a small capsular excess covering the edge of the intraocular lens, here is the problem, because you can have that scenario where you will have a viscoelastic entrapped between the lens and the posterior capsule. And in the early postoperative period, probably within the first week, sometimes the first day, you will have the lens push forward, you will have a myopia, shallow anterior chamber elevation of the intraocular pressure, and then this is called capsular block glaucoma. Then it has a specific therapy for that. So for the take-home messages, that intraoperative, you need to remove the viscoelastics and manage any posterior capsular rent. And then within the first few weeks, then think of the capsular block with shallow anterior chamber and myopic shift and steroid-induced glaucoma as well. Again, preoperative brimonidine, complete viscoelastic removal is critically important. Postoperative acetazolamide, paracentesis when needed, and the glaucoma operation is sometimes an option. And then I have to thank the group of glaucoma platform. They actually supplied me with great ideas for this talk. And with that, I thank you very much.
Thank you so much, Dr. Ahmed, for this valuable presentation, because this is a topic happen to everyone. Everyone have an IOP rise postoperatively, and due to in an uneventful surgery, he can have this complication. Questions, first rapid fire questions. Yes. The first one is, what about leaving the eye over pressurized at the end of surgery?
Yes, over pressurizing the eye, you mean with fluid? There is no problem, because you think of an eye injected with intravitreal injection, then the pressure will go up momentarily, so that if the outflow of the aqueous is normal, then after inflating the eye and then hydrating the incision, the pressure can go up, but within minutes, that excess pressure will go to the normal level through an intact trabecular meshwork, so that overhydrating a normal eye, it will be solved spontaneously in minutes.
Another question, he's saying, during the hydro implantation of the lens without viscous, do we place the IOL in the cartilage with the use of visco or not?
Yes, yes, we have to do that. And then you have seen that that at the beginning, some visco will come inside the eye. And for that, it is only the point that the mission will be very easy, because you just do a very, very little removal of the viscoelastic, not a lot of viscoelastic from in front and behind the lens. So it is just getting the mission extremely diminished to very few seconds. But actually, I don't have an idea if you put an intraocular lens without a viscoelastic. There is no recommendation for that, as far as I know.
In managing the posterior capsule tear with a significant vitreous loss, the eye is usually soft at the end of surgery after vitrectomy. But on the first and second day post-operative, pressure usually goes up a lot. Any advice?
Yeah, the point is, yes, that's the scenario. A lot of viscoelastic, usually we have pushed a lot of viscoelastic into the anterior vitreous, and then at the conclusion of the surgery, with the exposure of everything to the ciliary body, the pressure is towards the soft side. I tend to inject air at the conclusion of the surgery as well to pressurize the globe. And then that viscoelastic that's escaped behind the intraocular lens will come and elevate the pressure. So again, you have to keep an eye so that if a patient developed a posterior capsular rent, I would just put the patient on acetazolamide immediately after the surgery.
Thank you, Dr. Ahmed. There is a lot of questions, but maybe if you have time, we're going to answer a lot of it at the end.
Yes, sure. Thank you.
And now I'm going to introduce a very sincere friend to me, Meltos, from Greece. He's one of the expert surgeon in cornea and refractive. He is the president of the Hellenic Society in Greece. He's a very has a long experience in corneal surgery. Please, Meltos.
Thank you very much for your kind words and for this invitation. And I'm hoping that we can start this. Yep, I think that we are sharing the
very
slide.
Clear.
Good, excellent. So it's getting late, so I was trying to go quickly back to the basics for the corneal stromal edema, because it's a vast, big subject, and I will try to pinpoint a few things that will help the audience understand it better. So the basic stuff goes to corneal endothelium, which is just a layer of hexagonal cells. I would try to stress that it's a barrier and a pump. And the problem that usually happens when you do phaco is that you are damaging these aquaporins, which is an active transport ion system, which usually is at the edges of the hexagonal cells. And by doing that, basically you are stopping the pumping mechanism, and this is where the whole thing problem starts, because you are introducing overhydration of the cornea, and that's the basis of the whole talk. How are you going to examine, and which is useful for examining the cornea? I think specular microscopy, if you have it, or confocal even better, is helping. And recently, anterior segment OCTs are of a great help, specifically in some cases that we'll analyze later on. When you do have a confocal microscopy, don't just stop on endothelium cell density, but look at the coefficient of variation and the percentage of hexagonal cells, because these are the most important factors that will dominate the whole idea of how is this cornea that you have before the operation. And don't forget that as we grow older, the numbers are getting less and less, but the cells are getting bigger and bigger. So we start from 20 micron cells up to 40 micron cells when we are older. And these are absolutely normal. So these numbers for an 80-year-old patient are not bad at all. So we have again to judge what kind of patient we have in front of us. So see, you can see normal epithelium, over 2,000 cells. You can see the less cells you go, the bigger the cells. And also you start seeing, instead of hexagonal, you start seeing pentagonal cells as well. Of course, you have to use this kind of instrument for cases like Fuchs dystrophy. You have these black holes, good data. And polymegathelium is a very nice example where you can see small, large, or even larger cells. This is the beginning of a dysfunction of the cornea that might be at the moment in a cellular level. This is a very nice slide from Aladdin Asuri, and this you can see another disease, which is endotheliitis. You can spot the problems in the corneal endothelium. So what is a critical cell density? That means how many cells do we need per square millimeter? So we need probably 500 will do the trick and they keep the cornea clear without hydration if you don't do an operation. If you're planning for an operation, probably you need at least 1,000 cells because you will lose some cells in the process. Another important factor is that if you see a difference between one eye and the other, more than 300 cells, this is a clinically significant difference. Something is wrong in one eye. For polymegathism, that means that difference in size of the cells, I think the coefficient of variation of over 0.4 is a clinically significant factor. So it's a polymegathism, you have to look for that. And look for pleomorphism. If you have over 60% of hexagonal cells, it's a good healthy cornea. If you have less than 50% of hexagons, then it's a pleomorphism. Again, it's a sick cornea, maybe at the level of a cellular level at the moment, but it will be at the functional level once you do the phacoemulsification. What can cause a dysfunction? I think mechanical is the key answer to this, but of course, as we have discussed before, inflammation, infection, chemical injury, or a disease which is nearby like uveitis. What are the risk factors? I think preoperatively we have to look for Fuchs, which is a key player on the post-cataract corneal edema. Hard cataract, again, because of the high pressure, the high volume of energy that you're going to introduce in the eye, yes, but don't overlook chronic uveitis where you already have an endothelium which is sick, like in viral endotheliitis. Don't overlook glaucoma, which again, it's a factor that you have a sick endothelium. And from the other aspect, if you're going to look to check for the medication of the patient before the operation, check for amantadine, because if you overlook amantadine, now we're using it again more and more, not just in Parkinson patients, but also in Alzheimer and other diseases. So this drug can induce corneal edema, a significant corneal edema. So you have to stop this drug and then do the operation because it can be something which is reversible. It can, not always. So just to show you some subtle cases like a posterior polymorphous here and there, they might have corneal edema, usually localized. Very rarely I had to do a dissect on that. But these are cases of trauma, like forceps delivery trauma, where you can have these folds, and these are completely innocent folds. You can continue the operation without any problems. These are folds because of the tears in descent membrane. You can see how they are in the OCT. Or, and this is a different operation, different case, where you have folds in a horizontal aspect, like in congenital glaucoma. There the tears are in a different look, but also the endothelium is not functioning well. So beware of the folds. Sometimes they are innocent, sometimes are not so innocent. And again, beware of amantadine. What about high pressure? High pressure does make a damage in the cornea, in the endothelium. Some of the damage can be reversible. As you can see, here are high pressure in the beginning. Second day, you can see how this corneal endothelial cell change. Interestingly, you can see some mitosis of the corneal endothelial change on the second day of high pressure, which disappears when the pressure stops. But look what happens at the extracellular matrix, and especially in cytoskeletal. Don't forget, these are the areas of the barrier that I told you, and this is where the aquaporins are. So this is a control. This is how it should be a healthy cornea. Day 1 and day 2 after high pressure, you can see destruction, disorganization of the extracellular matrix. And here you can see that even when you stop, you manage to control the pressure. When there is now normal pressure, still there is some scattering throughout the cytoplasm. So there is a problem going on there, even when you are managing the pressure. So the pressure can be a long-standing problem. Diabetes, an interesting case, because yes, diabetics have a tendency to have corneal edema, Interestingly, those that have corneal edema are going to have also pseudophakic cystoid macular edema. So it seems like both mechanisms are related to this unique problem of diabetes, that if you have edema postoperatively, most probably you will have cystoid macular edema. An interesting topic, I think. What about intra and postoperative factors? As I said, most important, excessive phacopower. Yes, you may have some drug toxicity from irrigating solutions, but this is not the problem. DMD, detachment, we'll have a quick discussion a bit more later on. Try to differentiate TAS, because TAS does have at least fibrinous uveitis as well as corneal edema. It's a different story, and usually, very rarely, TAS you have to do something about the corneal edema in TAS. Yes, we may have cases, but we have to do something for the corneal after TAS, but it's very rare. Please take care of all the fragments or vitreous which is left after your cataract operation. They are there when the patient sleeps. All these fragments may actually traumatize continuously the endothelium, and this can cause chronic inflammation and trauma. So two mechanisms in one in these cases. Operating tips. Let's start with patient counseling, because this is the most important tip I can give you. If a patient has some risk factors, you have to be careful, and also carefully counsel that there might be a chance after the cataract operation to have another operation, a more expensive and more difficult operation like DMEC or DSEC. Try to keep everything away from the cornea, so limbal incision, dispersive viscoelastic. This is our soft cell technique. I think is an excellent technique for that. So for the phaco operation, I think low power, full chop, torsional, small incision, everything you can do to have as less phaco power as possible. And please do not use, if you see patients with Fuchs, patients with some sort of abnormality or some sort of endothelial dysfunction, do not put multifocal IOLs. It will be a disaster. I don't think that you will have a happy patient postoperatively. Even if they do a DMEC or DSEC, I don't think that at the end they will be that happy. So what to see in these patients? Patients who have a central thickness of the cornea of more than 440 microns. Probably you have to discuss, or they have macrocystic edema, or they have less than 1,000 cells. You have to prepare them that they may need DMEC. In my case, I will just go for DMEC, triple procedure, phaco, DMEC, or phaco DSEC. Or if they have only a centralized damaged endothelium and the periphery looks okay, I may try, I haven't tried, but I'm thinking of the shortage of tissues that we have to try. Desmetorexis without transplant. So this is a future thing. What about membrane detachment? This is a big problem. Here is a very nice picture of a shallow membrane, but this is the same patient again. If you go a bit further down, you can see it even more. But you can see there's a big pupil on this patient. So there is also vitreous strands and a lot of problems in a sick and maloperating eye. Some of the factors are similar to others that we've seen. Old age, a dense cataract can be a descent membrane, can be a risk factor for descent membrane detachment. But obviously, endothelial disorders also play a role on that. So here you can see a very shallow detachment that you don't need to do anything for. Sometimes it just completely disappears, shallow and very centralized in one area. And here you can see the patient that I showed you before, where we do put air. There is still an area of a small detachment here, and but the rest of the descent is very nicely attached. So there are two interesting papers, both from India, one from Dr. Kumar and the other one from my good friend Namrata Sharma. Dr. Kumar was the first one to create an algorithm of all these detachments. Namrata used this algorithm with AC, OCT. I think both of them are worth looking. When you have these scrolls or you have very high detachments, you cannot just leave them. You need to do something, like in these cases of a wavy detachment with a cut here, or very high detachments with very big distance between the desmet and stroma. These are cases, or the case that I showed you before, that you have to use air, and maybe air with SF6, certainly air with SF6. But this, we'll talk about it later. Medical treatment, generally medical treatment when you have edema, hypertonic saline, or recently some ointments, I think they can do the trick in the beginning. Yes, you need some steroids if you have signs of inflammation, and to avoid also fibrosis. So steroids are also useful in the beginning. Lower the pressure, it helps a lot. Bandage contact lenses in the beginning with antibiotic drops, it's a very interesting, it's something which can be a very short-term, 3 months or 2 months use. It is very helpful. Maybe, and I'm waiting a lot for ROCK inhibitors, ROCK inhibitor that is used in Japan, and we are using it also, but it's very difficult to find it. Once it can be more broadly accessible, it will help a lot in cases of postoperative edema, or even to use it preoperatively in Fuchs cases. And hydrogen is a very interesting option. Hydrogen can help reducing the hydroxylic free radicals. It has been used in vivo and in vitro in some irrigating solutions, and I think that can be an interesting adding into your irrigating solution when you do high-risk patients, to induce some hydrogen and then try to reduce the amount of hydroxyls. This is an interesting lens, hyper-CL lens, that you can use for 7 days and then change it, maybe even 14 days, they say. It has this fenestrated, so you can also use some hypertonic solutions to reduce the corneal stroma. You can see if you use 7 days, the corneal stroma thickness is getting less. Another interesting option is to do desmetorexis and then introduce this endoart, this artificial biomaterial at the back of the endothelium. Has been shown in very early, it's still very early for this, but it is shown promising results. We're still waiting to see if that can also do the trick in some cases. Going back to desmet membrane detachment, I think we will go directly to these two algorithms, height, extent, and length, which is very important in the first algorithm, and of course, where is the problem? So just to point out, when the problem is central, when the problem is the periphery, you don't need to do much. You can just put air or even leave it. If the problem is central, then you have to put air in, you have to do gas or even mixed gases, especially when you have a height, or you are dealing with zone 1, which is a central zone, or zone 2, which is a mid-peripheral. So central problem is a problem. Again, on the Namrata's paper, inferiors are those that you have to deal very carefully. Inferior detachments and extensive detachments need intracameral gas and intracameral and probably also a kind of gas. I don't know whether C3F8 is too much because it stays about 6 weeks, but certainly you can use a mixture of 20% SF6 for which will stay for 2 weeks, and it will make sure that it will drain the whole problem. This is a case, again, we have put here SF6 about 2 weeks post-op, and you can see that there's also, don't forget to do inferior peripheral iridotomy. And this is before. In this case, we had to do extensive vitrectomy. We have to also separate some fibrous tissue which was related to the incision, and then put air. So yes, it's quite a difficult operation in some cases, but we have to do it. You have sometimes to do also desmetotomy, or even put a suture on desmet to try to stick it back to where it is in the stroma. Also, don't forget to remove everything else that shouldn't be there, like lens fragments, do vitrectomy. Do not wait too much if you have a dislocated IOL, because you don't know where this IOL sits when the patient is in a supine position when he sleeps. And of course, you have to deal with the endothelium either with DSEC or DMEC. In non-seeing eyes, you may get away by just introducing silicone in mid-stroma, and that can be an interesting topic maybe later on for a discussion. You just put a little layer of silicone, the same silicone that silicone that they use in vitrectomies in stroma, and that will prevent water from coming in front and doing bullous keratopathy. And in short term, you can just cover the cornea with amniotic membrane and conjunctival flaps. What I want to leave you with, first of all, look for coefficient of variation and the percentage of hexagonal cells. It's very, very important. If you see some problems, just cancel your patients. If you have a thick cornea, or if you have an endothelium cell rate less than cell density less than 1,000, I think you have to consider more of doing a combination, because these patients, even if they don't manage to do, even if they skip the problem with bullous keratopathy, certainly they can have a very low visual acuity. In cases of a central, extensive, or inferior descemet membrane detachment, it requires urgent pneumatic desmetopexy, requires air in the AC or a combination of gases. And please don't leave fragment, viscid, or dislocated lenses a year or two. It is malpractice, at least in my eyes. Hopefully, maybe this year, certainly next year, we will have pictures like this. But I wish that we will have them also this year when we're finishing with our lockdown, which still is a factor of a problem in Greece. Thank you very much.
Thank you.
Thank you, Melto, so much. It's a very strong presentation, and we all learned a lot. I'm going to just small questions for you, because you have many questions, but I'm going to just 3 questions.
Yeah.
Does injecting air in the
questions?
Okay.
You have 4 questions. Excellent.
Does injecting air in the anterior chamber may cause the pupillary block? I did hundreds of times and does not see it is really real.
Well, in my hands at least, okay, it is not like doing a DMEC that you inject air and then you can deflate a little bit and you leave an air bubble a little bit more than your DMEC graft. There you don't know the extent, so you have to have a full air in the beginning. And then what I do, of course, I will always do a peripheral, inferior peripheral iridotomy in all cases. And I see them retrospectively the next, then same night and then the next day. But if you're going to use in extensive descemet membrane detachments that you may have to also, I remember a case that it was an anterior chamber IOL where there was descemets around the IOL haptic that I have to do a desmetotomy and then to air to try to fill, to make it a bit more looking like an eye. In these cases, you have to leave the air at least for 2 weeks and even more. So in these cases, if you leave F8 for 6 weeks, you know, it's too much. You have to be careful with these things. But 2 weeks with SF6, I think you have to deal with it. Some people do cycloplegic, but I'm worried to leave it just with cycloplegic.
Do you prefer to inject intracameral air in all your phaco?
If I have a descemet membrane or at the end of all my phaco? No, I don't. No, I don't. But if I see somehow that I'm not happy with my incision, somehow I see that my incision is not a perfect step, or I have done too much of phaco and I think that my incision is not a perfect incision, then yes, I will just leave a little bit of air. So when the patient is standing up, air will go up to the upper third and dehydrate my incision and help my incision to seal better. In cases that I don't like my incision, yes, I will leave a little bit of air, only in these cases.
My last question, what about the preoperative subclinical endothelial dystrophy of insufficiency?
Sorry, what about?
Subclinical endothelial dystrophy.
Okay. When is, as I said, in the cellular level, I think that coefficient of variation and hexagonal self percentage, these are two factors that we have to consider. But I think the key point to whether you're going to do a triple or just a phaco operation, the key point is your central corneal thickness and your microcystic edema. If you touch the epithelium and you see that the epithelium is a little bit moving, you know that there is edema under your epithelium. So all this edema, all this water came from the back. It's bad news. This epithelium is already, let's say, detached from Bowman's. This epithelium will certainly do bullous keratopathy after the phacoemulsification. If I just see at the cellular level, I will leave it and I will try to do a few tricks to try to make it as full as possible, my phaco.
Okay. Last two questions, one for Dr. Fathi and one for Dr. Ahmed Mustafa.
Yep.
One for Dr. Fathi. Do you experience do you encounter situations when the bag was fibrosed and couldn't open, or it was shrinking and you couldn't implant an IOL in the bag after you are inside the eye? What can you do?
The answer is yes, but again, it's a rare situation. Like I've shown, in most of the cases, the capsular bag could have been opened, but in this case, definitely I would implant in the sulcus and then make sure that I can close down the pupil and probably have a peripheral iridectomy.
Okay, Dr. Ahmed Mustafa, if the patient was glaucoma, and controlled only with one medication or two, do you believe in just phacosurgery to control the IOP, or we must proceed for combined surgery? And what is your protocol?
Thank you very much for this question. Yes, the point is that will depend on what type of glaucoma the patient is having. If the patient is having angle closure glaucoma, and then you can do only phaco, and you can add to your phaco goniosynculitis after proper examination of the angle and to see where are they are closed. So again, with the angle closure glaucoma, still you can do phaco because the percentage of IOP reduction following cataract surgery is great. Now it will come to open angle glaucoma. The problem is that if the patient is controlled with one medication and the optic nerve is really good, and then you can do phaco, but you have to counsel the patient that the patient might still continue on the same medication in the post-operative period, because most of the results documented a little reduction in the intraocular pressure, like 1, 2, 3, 4 millimeter, and then this might not be for a quite long number of years. So again, yes, if the patient accepts that, then it's okay, we can go for that. Now, if the patient is using more than one medication, or the patient is having significant damage to the nerve, now it is much, much, much more safer to do a combined surgery. I opt for that and I push the patient for that. Because one of my patients I have seen here that she was using the triple medications, and then she went for phaco, and then she got her intraocular pressure crazy and uncontrolled in the post-operative period. Then we have to do a glaucoma operation under very unfavorable situations. So again, the answer is that you need to know which type of glaucoma you are dealing with. Angle closure, yes, you can proceed. Open angle, be cautious.
At the end, I must
I have a minute for a question for Dr. Meltos.
Okay.
Yeah.
It's not uncommon that we get a small piece of desmus membrane detachment around the phaco wound. My question is, why does this happen, and at which step, in your opinion, and how would you avoid it, and have you ever needed to do something about it?
I think what happens is that when you have a little bit of a detachment, especially when you're introducing your lens, I think that's where most of the detachments do happen. When you have a suture and you're using this kind of forced suturing of the lens on a small incision, that's where you're pressing too much in your incision, and that's where you may have, if you have a little bit shallow incision and you have your suture in, then it's really, really easy to make a small membrane detachment into a bigger membrane detachment. If you see that, Again, you put a little bit of air, have the patient standing up for the rest of the day. I'm talking about only 1/3 of the anterior segment area. So that's a little bubble. And then the little bubble will dehydrate the incision. If you dehydrate the incision, everything will stack up together nicely. So I think if you see a little descemet membrane, again, put a little bit of air at the end of your operation, and that will stick. What happened to me?
Any relation to the construction of the wound, the way you do the wound, whether it's posterior or anterior, long or short?
Most of the cases now, I think we do this one-step incision or a kind of a two-step. It didn't happen in the past when you used to do this three-step incision, but now with a one-step incision, it's much easier. If it's not 2 millimeters, but it's 1, then you can understand that this is too steep. So if it's 1 millimeter incision and a steep incision, definitely you will get, if you push too much your introducer, your cartridge, yeah, definitely you will have something. It doesn't happen with the phaco-tip. I think it happens when you introduce the lens. I mean, what happens to me once, and I still remember it, it was when I was hydrating my paracentesis, I managed to do a beautiful dark. The whole descemet just separated, hydrated away. I couldn't do it when I'm doing dark, but I did it on phaco. So I had to go out and then put air and then put it back. Sorry?
We all had it once in our lives, yeah.
Yeah, exactly.
Can I ask a quick question? I think that's for benefit for everyone. Yeah. In fact, it's 2 questions because this is a kind of come from examples I see in my practice. We both cornea surgeons, we referred cases with patients got cornea decompensation after cataract operation. That could be just 1A patient had a tiny gottata, and this is the first question is, if you have, what's your advice, if you have a patient with very, very minimal gottata, so it's tiny changes on the cornea endothelium, good cell count still, would you recommend that patients can have a multifocal lens? Because there's a trend that we give those patients the best surgery, the multifocal lens, etc. There's a drive for that, we know that. And the second question, which is very practical, what's your most single advice for those surgeons who end up with complicated cataract operation and they said, oh, okay, what they need to do before they refer the patients to you? Because these patients obviously end up with a corneal edema. They're not sure what happened. Did I hit the DCMA? Did I damage the cells? Is it a long surgery, etc.? So what's your most single advice to give
I will start with what I hate. I will start with what I hate in my practice is when I see patients coming back after 1 year or 2 years with a contact lens on, and in some cases with an infection due to the long-standing contact lens without any antibiotics. So they have a contact lens for a year. They start having fibrosis of the stroma because of the long-standing edema. And then these cases, even if you do a perfect DSEC or a perfect DMEC, still you cannot improve the visual acuity that you should have done if they can repair. So my impression is after 6 months, refer the patient. Don't wait for contact lens related problems to refer the patient. I think 6 months is a good period to do something, and I don't think we have to wait more than 6 months for that.
What if this is a cataract patient because of complicated cataract operation?
Yeah, the same. If it's a complicated cataract operation and they have, so that's another story. If they have vitrectomy, if they have vitreous, if they have retained fragments, the moment you see that, you have to operate next morning. For me, if you see a vitreous, if you have a dislocated IOL with vitreous strands, with fragments, or an ACIOL, and you start seeing a decompensated cornea, try to operate as quickly as possible. Cancel the patient that even if you do that, you may need another operation later on, but do that as quickly as possible. Sometimes when I see a little bit of edema post-operating cataract, as you said, I do a bit of gonioscopy, and if I find 1 or 2 little pieces, I go in the same day, do a little bit of IA in the anterior chamber, and then that may solve the problem. Yeah. Now, going back to the problem of cornea. Now, what is the major problem when you have patients with fuchs? You have the lamellar hydrated, so the lamellar are getting a bit distant, and then you start having reduction of the contrast sensitivity. So you have one aspect, which is a cornea, which already doesn't have the perfect contrasensitivity, and you're introducing another optical system with a low contrasensitivity function, a lower MTF. So you have now two systems with a low MTF. For me, if I have corneal thickness even more than 550, even more than 500, even if I have 580, 590, I would not put, I would just do phaco with a simple contact lens. If I have a patient with a few good data, with a good otherwise coefficient of variation and endothelial cell density, and corneal thickness of 540, 550, yes, in these cases, I might discuss with him the possibility that in the future, things may not be as good as what it is now, but we can discuss the possibility of a trifocal lens, not when they start having a little bit of edema. I think this...
Okay, thank you. For the sake of time, we should close this because Dr. Ahmed...
You can continue with the beer.
Yes, I must thank everyone. I was honored by everyone here in this webinar. It was a very interesting webinar. We are, the participants are with us till now, a big number. I don't know, they are waiting for us more than 2 hours now, but really it was a precious presentation from everyone here in the webinar. Thanks for everyone, and thank you so much. Thank you, Meltos. Thank you, Dr. Ahmed. Thank you, Dr. Fathi. Thank you, Samer. Thank you.
Thank you, and see you in Greece maybe next year.
Thank you so much, and thank you, Eva, so much for this webinar.
Thank you, Samer. Thank you,
Dr. Ahmed.
Thank you.
Thank you. Bye-bye. Bye-bye.